So bringing a model from development to the practice is not always an easy process. And you would have to develop the model, starting going through different phases, trying to make sure that in the end it is fit for to be used in practice. So first you'll have to define the problem. Then often you look at what are existing models for this outcome and problem. Then you may want to validate, look at how well this model actually performs. You might want to slightly adapt the model so that it fits better for your particular problem. And then once you have a model which actually makes good predictions, then you still have to see if it actually improves the clinical process. So it doesn't mean that maybe if the physicians don't use the model or don't look at the model, then it also doesn't help. So that's also an important part to assess. And then once that evidence has been generated, then they could be used in practice. And as you can see, there are some arrows. So sometimes you may want to go into development, but then you find out there's a problem and you have to go back to the drawing board. So it's not always that you go from left to right. Yeah, so the first step is really about defining the problem. So what is the patient group that we are interested in, and in what setting? Is it in a hospital setting, in a primary care setting, or is it maybe even for the whole population? What is it that we predict? So is it diagnostic outcome? Like, do we want to predict something about the patient at this very moment? Or do we want to predict the future outcome, like the cardiovascular risk? And how will it be used? So is every physician going to be using it, or is it only on certain conditions that they will use the model? So these are all really important parts to define if possible, at the very beginning, together with the clinicians working in the field, because they know about all the barriers that are there and what actually is needed. And then, the first reflex often is to start developing a model. But we usually aim to recommend first looking at what is already out there. So do a systematic review about existing models, because that may inform you very well about how to design your own model, or maybe there's already a model out there and you can just update it and then use it. And it would require less data usually, so that can also be an advantage. But then if there is no existing model, then you can immediately start model development. But then again, you would really want to check, do I really need to? Because there's so many models that are probably that if you didn't find a model for the thing that you are trying to predict, then you should maybe go back to the search, because they're almost for all outcomes, or I mean, there are many models these days out there. And also, if you need to develop from scratch, then you need to have one set of data for development, but also then data for evaluation. So it just requires a lot of extra resources. So there's a small poem about this point in particular. So it's Choose Your Models from Robert G. Worry. So models are fine and statistics are dandy, but don't choose too quickly just because they're handy. Stick to a model that's been through the mill. Don't try something new just for the thrill. A shiny new model is full of allure, but making it work is no sinecure. So this is just to really stress this point again, that to try to suppress this reflex to start model development immediately. Yeah, so if you somehow ended up with a model, either because it was already, you identified it in a systematic review, or because you did develop a model, then you want to validate this model. And yeah, the aim of this step is really to to evaluate how well does this model predict the outcome that I'm interested in new subjects that were not used to develop the model. So this is really about how well the prediction itself is going. Yeah, and there are different ways to validate this model, or different aspects to look at. And the aim is then, or how this usually works, is that you take the developed model and you apply it as is to new data from unseen patients, and you compare what the model predicts with what is observed in those data. So, and then there are different parts of this evaluation, but what really is important then, that if you predict that someone has a certain cardiovascular event within 10 years, then you hope to see in that patient for whom you predicted that it is also happening. And for those who you did not predict that, or a low risk, you predicted low risk for certain patients, then you hope that it happens. It doesn't happen really. Yeah. And
so for this, you don't have data of people who have been followed up for 10 years or longer, then you cannot validate. When you develop a model, you always need data for the time period of interest of your prediction, or you are limited. You can only predict at 2 years. You cannot predict at 10 years if you don't have enough patients followed up for 10 years to validate your model. And so probably in rare diseases where we didn't have patient registries until very recently, it's probably difficult to generate longer term data for middle or longer term predictions, right?
Yeah, indeed. Yeah, so that's if you have if you predict very far, if your model predicts very far in the future, then it may take a long time to follow up, to do follow up. Yeah. If that was not, if the data is not somehow recorded already in an accurate way. Yeah. Yeah, and then another aspect is that if you want to validate existing models that you identified in a review, for example, then it really, then those models should be really nicely reported. Otherwise, you cannot, you cannot apply the model to new patients. So they need to, all the coefficients or the parameters of the model should be reported, and the way the outcome and the predictor variables are measured should also be clear. Because if you measure things in a different way, then it might seem that the model doesn't work well, but that it's really because you didn't measure in the same way as how the model was developed. Yeah, so then there's to ensure this proper reporting, there's different reporting guidelines available, basically. And this makes it a bit easier to do this systematic review also. So so when you develop a model, then it's also, so to speak, recommended to follow these reporting guidelines. Yeah, then at the very beginning, I mentioned that the data you use for development should be representative of the setting in which you apply the model. And depending on if there are differences between those two, so there are different types of validation. So for example, usually you use historical data to develop the model but you will only apply it in future patients. So that means that when you validate in a different time period of data collection than when it was developed. And this is then called a temporal validation, because in a way it could be that there's still a time effect, and that is then also captured in the validation. And another type of validation is geographical validation. So there you maybe have developed a model in one center and you want to validate it in a different center, see how well it performs there. And this can also, this can be interesting to see if maybe one model generalizes well to different centers, because that could mean that you don't have to develop new model for every center, which is maybe something that you would, in some settings you may want to have that on a national level, the same model is used or something. So then this is quite, something that is important to consider. And then sometimes there are also different, groupings basically. So it might be that a model was developed in primary care, but then you may also want to use it in secondary care or in hospitals. And then there's also a change in setting. So you would want to explicitly validate that. But the most important part is really that you validate in the setting in which you want to use the model. Yeah, so then there are different types of validation. So what can happen is, because the models they predict or they provide for each patient a probability of experiencing the outcome. But it can be that the model, for example, always predicts too low probabilities for everyone. And that's what whether the probabilities correspond to the observations, to the frequencies in the real data, that is called calibration. And there are sort of two aspects in this. And the first is to see are the predictions or the probabilities in overall too high or too low. So, and that is done with a plot like this. And then on the x-axis, so it's a bit technical, but on the x-axis they have the predicted probabilities, and on the y-axis they have the observed frequencies or the proportions of the outcome in different groups. One for each point is a group. But what you want is that those are the same. So that if you pick a group of patients, you do the predictions for those patients, and if the model says 10% of these patients will experience the outcome, then in your data you would wish to observe that 10% of those patients did experience the outcome. And if that is the case, then the line will go on the diagonal, or will lie on the diagonal, but now it's below the diagonal completely. So that means that all the predictions that the model, or I mean, in general, the model predicts too high probabilities for this setting. So that's then a problem that you may need to fix. And another thing that can happen is that this line is not completely below the diagonal, but somehow tilted. That's called calibration slope. And here, for example, you see that for the low predicted probabilities, it is above the diagonal, which means that the predicted probabilities are too low, because for a predicted probability of 0.2, the observed probability is around 0.3, the proportion of the outcome, so it is too low. But at the same time, for high predicted probabilities, so for high risk patients, if the model say predicts 0.9, then the observed probability is 0.7. So at the same time, it can be that the model predicts too high probabilities for the high risk patients and too low probabilities for the low risk patients. So these are kind of problems that can happen and that you can detect when you validate the model. And it's really important to know, because if you make a prediction and the model says 40%, then you ideally want that this patient or the characteristics of this patient really correspond to having a 40% risk. And it shouldn't be 30 or 50 or. Yeah, so at the beginning I mentioned that the patient group of development and should be a representative for the application. But when you validate, quite often this is not the case. So you do take a model from a different hospital and you validate it in your own hospital, and then you actually know already it's a different hospital. So undoubtedly there's something that has changed in the setting. So you kind of know that when you validate the model, it will probably be a bit worse than how well it performed in the hospital where it was developed. And this can be because there are differences between the hospitals. So there could be different proportions of the outcome. It could be that more severe patients are treated in some hospitals. It could be that, different patients in another way. So it could be that in one hospital, the average, maybe one hospital is specialized in childcare. So there are way more children being treated in the hospital. So there can be many, differences in setting. So it's not immediately a problem when you validate a model and it is a bit poor, then it's not immediately problematic. It is kind of surprising if it is not the case, actually. And the only thing that really matters is if it is too poor, so to speak, for your purpose. And even if it isn't working so well, then it's still not a reason to start developing a new model from scratch always. So that's something to remember, because if you during the model development, a lot of information is going into the model based on the data from this other hospital, and you really don't want to put this aside unless you really have to, because you ideally don't want to ignore information. But there's another option, which is to adjust the other model. So that's, now we come to the updating part. So if you observe that the validation wasn't perfect, then you can update the model and correct, for example, this calibration curves that we just saw. And what could be considerations when you want to update the model? So it might be that there are, on the one hand, it could be what I just mentioned, so that it's a new, this is the second point on this bullet, so that there's a new setting, basically. That is, so that you have a bit more data from the new setting, which is a bit more representative of your population. So you want to update the model a bit with this new data. It could also be that some new research was done, which identified a very important predictive factor of the outcome that you're interested in, that you would want to include. But it could also be simply because there were issues with the initial model development that you want to fix. So and as I mentioned before, sometimes it might be that you want to ideally use one model on a national level, for example, and then you want to either develop the model on the national level or do only small alterations locally, basically. So what one way to adjust the model is what I mentioned before, is to change the intercept, or intercept adjustment, that is called. That means that you can change the overall predicted risk of models. So if it in general predicts too low probabilities, you can just increase the probabilities, or make the model, adjust the model accordingly. And one more appropriate way to do this is the closed testing procedure. So there you really test, like, do I need to update and how much do I need to update? That's basically captured in this procedure. So if you have identified other models, you have updated them to your local setting, but the performance is still not good enough for your purpose, then probably you would want to develop a new model. So that's kind of because then then you really, and the advantage, so if you develop the new model, then you will also need to have new data to validate it again, but at least you will find out at this point. So the last two steps are, once you have a model which really predicts well, you still want to check, does it actually improve patient outcomes, or the purpose which is or the treatment process. And that's the model impact assessment. Yeah, because at the beginning we mentioned the reasoning how prediction models could help in the improved patient outcomes and the physician making process. And this really was based on that via accurate and objective probabilities, this can inform the physicians to make better decisions about treatment or about diagnosis. And via that route, there can be a better treatment process leading to better patient outcomes. But the aim of this, this still needs to be tested. So even if you have a good prediction model, you still want to test if this actually is happening. That's the aim of the model impact studies. So to see whether the prediction model really improves the decision making and the health outcomes that come from that, and ideally even the cost effectiveness of care, because more efficient decisions were made. And there are different, so there are different designs to do this. So the classic design and the most, if possible, very good design is the randomized clinical trial, where you directly evaluate how well using the model compares to not using the model. So you directly validate, or you directly try to estimate what you want to know. But the downside is that it can take a long time, and that it's usually costly. So if you recall if you have a model that has a 10-year outcome, for example, you will have to wait quite a long time before the predicted risks lead to better outcomes. So that really depends on the setting, if this is really the way to go. So there are also other ways to do this. So you can also do cross-sectional studies with intermediate outcomes. So then you don't really check necessarily the final outcome that you're interested in. Let's say you want to reduce cardiovascular mortality, which may, for example, for young patients may happen very infrequently. So then an RCT is not necessarily, could take a really long time. And then you could do, for example, also do a cross-sectional study with an intermediate outcome, where you just see if the decisions made by the physician change when they use the model and how they change. And then, so you don't then directly evaluate the final outcome that you're interested in, but you could actually really do this study a lot faster. And if the physician, for example, wouldn't use the model, in the extreme case, then you would already identify it at the start and not at the end, so to speak. Then there's also before-after studies, so where you do a similar thing, but you compare, you first introduce the model, then you do the study for a while, and then you don't remove the model again, and then you follow the outcomes during that period of time. or the other way around. So then, yeah, but in any case, you change the groupings in time. Yeah, and another way to do it is just via modeling itself. Yeah, so then you calculate an expected effect based on how you know that certain maybe risks are currently used in the decision-making process, and then you change those risks based on the model, and then you you simulate basically how that would impact the final outcome that you're interested in, based on what you know about the current treatment pathway. So that could, and that is something that you could even do sometimes without, without having to involve any patients. So that could be done really quickly in that case. So there are really different ways to approach this.
Do you know if randomized clinical trials to model this impact, to assess the impact of the models, are frequently conducted, or it's exceptional to have RCTs to assess these models?
Yeah, so to my knowledge, the impact studies in general are not frequently conducted with these models. But I know that there are a few RCTs, I think, with certain models. But I think, for example, in radiotherapy, they have these diagnostic models based on images, and I think there have been RCTs with those. But it is very rare compared to the amount of models that are developed, so to speak.
Because when you are in such a randomized clinical trial, you cannot take part in other type of clinical research. For example, if in parallel you test a new medicine, it can impact the outcome. So for patients, it's maybe difficult in terms of utility to see the utility of being enrolled in such a model impact study compared to a pharmaceutical product trial. I would presume.
Yeah, I can completely understand that there are different, that it is maybe less attractive to join this kind of study compared to certain other studies.
I just have a question then on that as well. So based on this, do you think that, let's say, the modeling exercise could gain in terms of popularity and utility if we increase the number and the quality of the data that we have at our disposal? Is that likely to increase the utility and the validity of modeling exercise compared to randomized clinical trials?
Yeah, so I do think that if data is registered nicely, that it makes the whole process easier. So the development, the validation and everything, because you simply, you just need the data to do those things. But I also, I'm not sure how they compare to each other, but I also think that more model impact studies are like really good, are sort of strong evidence to start using a model, which is also very problematic. Or problematic, I mean, from everything that's being developed, only very few are in the end being used. And I can, so I could definitely see that doing more impact studies could help there. Yeah, but if there's good data collection, that is definitely, at the basis almost. Yeah. Okay. So that's also the end, basically. So I hope that that this presentation gave at least some idea about how this process from model development to use in practice goes or can go along all these phases. So and as mentioned, I don't have that image here actually, but the majority of models are being developed, and then it's really steeply declining towards the number of models that are being used in practice. So there's definitely some work there to see what is the exact reason for that.